All right, everybody, Dr. Rayford from Vet Triage. We are continuing through this issue of Veterinary Surgery, November 2024. It's this one, description of cricotracheostomy technique for permanent tracheostomy in 8 dogs. Another cool paper that describes and report the outcome of a cricotracheostomy technique for the creation of a permanent upper airway ventral cervical stoma in dogs. And this is a short case series of 8 dogs. This comes out of the Animal Medical Center in New York City, the vet school in Michigan, and vet school in Florida. The results found the stomata did not show any evidence of dorsal wall collapse or stenosis. 4 dogs required further skin fold resection. The owner questionnaires reported high satisfaction in the postoperative quality of life. Introduction: permanent tracheostomy surgery, an uncommon procedure, is performed for the conditions causing irreversible airway obstruction of the nasopharynx, larynx, and proximal trachea. Causative entities include cancer, inflammation, dysfunction, trauma, Norwich Terrier upper airway syndrome, and irreversible laryngeal collapse associated with laryngomalacia or bicephalic obstructive airway syndrome. The surgery produces a permanent stoma by accurately, meticulously opposing skin and tracheal mucosa. The most common technique involves the removal of cartilage, approximately 3 to 4 tracheal rings. The location may vary depending on the site of obstruction, but it's typically at the most palpably superficial portion of the trachea. It's been recommended that stoma placement always be cranial to the 12th tracheal ring due to an increased mortality rate associated with caudal locations. In the postoperative period, tracheal mucosa undergoes squamous metaplasia. During this transition, inflammatory infiltrates produce exudate, which in addition to mucus production can cause marked respiratory compromise and even asphyxiation via mucus plug obstruction. Complications include aspiration pneumonia, skin fold occlusion, stenosis, or collapse of the stoma. Collapse of tracheal cartilages around the stoma is not as commonly seen as stenosis, but in traditional tracheostomy there is only cartilaginous support laterally with no support dorsal or ventral. It is important to note that increasing the length of the stoma decreases the chance of stoma stenosis, but it increases the risk of stoma collapse. In a preventative or revisional manner, extraluminal support can be applied cranially and caudally to the stoma in an attempt to support the trachea. Extraluminal support of the trachea with ring prosthesis increase surgical time and complications, including infection and disruption of blood supply. Of 24 patients requiring revision surgery following permanent tracheotomy, 21% were attributed to tracheal collapse due to dorsal wall collapse of the stoma. This is not surprising, as removal of 30 to 40% of the ventral aspect of the C-shaped cartilages results in only lateral cartilaginous support, and the dorsal aspect of the trachea is not supported by cartilage. The cricotracheostomy technique originally developed because the traditional tracheostomy could not be performed due to the presence of an intraluminal stent in the trachea, another case. This procedure involves removing the cartilage of the ventral transverse 40% of the cricoid and the first 2 to 3 tracheal rings, maintaining the considerably wider dorsal lamina of the cricoid cartilage, providing robust and rigid dorsolateral support to the stoma. And so this is a figure here. The red triangle delineates the typical location of the cricotracheostomy right there. So epiglottis, arytenoid, thyroid cartilage, and cricoid cartilage, and you see that red box there, and that's the new placement of this permanent stoma. These cases are from 2014 to 2021. A rostral caudal incision over the trachea, midline, larynx, and trachea from the basihyoid bone to the 4th tracheal ring. Sternohyoideus muscle bellies are separated. The pair cricothyroideus muscle bellies are elevated. Cricoid cartilage and cricothyroid ligament. The ventral transverse 40% of the cricoid cartilage and most cranial 2 to 3 tracheal rings are separated from the underlying submucosa, leaving the cricothyroid ligament and membrane, laryngeal and tracheal submucosa, and mucosa intact. So here's just some pictures of the surgical approach of the dog here, and then the surgery picture, and then here's some drawings showing the exposure of the trachea and what's going to happen with the muscle bellies. Then the additional stoma size rostrally was achieved by resecting a small portion, about 5 to 8 millimeters, of the ventral caudal aspect of the thyroid cartilage, again preserving the laryngeal submucosa and mucosa. They made a wide H shape ventral midline and transverse incisions of the cranial and caudal most aspects of the stoma. And then appropriate skin fold resection was considered critical to an optimal outcome. And in this picture, I'm going to show you the completed cricotracheostomy. The redundant skin is resected, endotracheal tube placed to the temporary tracheostoma during the procedure. And then with the drawing picture, the proposed resection of the cartilage includes the ventral transverse 40% of the cricoid cartilage and 2 to 3 most cranial tracheal rings, dotted line, and the underlying mucosa, submucosa, including the cricoid ligament cranially, incised sharply in a wide H shape. So in the top picture, you have the real stoma with the endotracheal tube going in with this temporary stoma, and then the bottom, the drawing showing supporting the trachea with muscle bellies, and then excision revealing the submucosa. Pretty cool. And then this picture here, you see the final healing stomas in these dogs. A is a healing stoma, B is a healing stoma 1 to 2 weeks after CT scan and skin resection. All right, results. These dogs underwent permanent cricotracheostomy. Both surgeons noted that dissection and separation of the ventral cricoid cartilage away from the underlying submucosa was easier than the tracheal cartilage rings. Tension-free and accurate apposition was considered critical to avoid dehiscence and stenosis. No stenosis was seen, although all stomata became approximately 30% smaller as they healed, but tolerated, improved quality of life. The greatest concerns for pet owners were fear of hurting their dog when cleaning the stoma, pushing exudate into the airway during cleaning, and the dog getting too much exudate buildup overnight and suffocating. These are all reasonable concerns. And this is a U-shaped incision to remove some more skin over this dog's stoma. Owners were taught to cleanse the stoma daily with sterile saline and clip around the stoma monthly. All right, so discussion. This modified high tracheostomy incorporating the cricoid and cricothyroid ligament into a permanent stoma was described. This is suitable for glottic and supraglottic obstruction, but would not be used for infraglottic obstruction involving the cricoid. Permanent tracheostomy is uncommon, not simply due to limited patient population requiring a permanent stoma, but also due to the historic perception of unfavorable outcomes. This revised technique, incorporating the cricoid, might change those perceptions. The high position of the stoma is functional, easy to maintain, less prone to obstruction, as the laryngeal portion is large and sturdy, and the cranial trachea is wide and the cartilages are thick in the most cranial aspect. While the procedure location differs from the traditional tracheostomy in that it's not performed over the most superficial tracheal location, there does not appear to be adverse consequences. The larynx becomes more superficial when the sternohyoideus muscle bellies are separated and the cricothyroideus muscle bellies are removed. The cranial trachea is superficial with mattress sutures as described in this technique. The mucus and exudate production appeared comparable between this procedure and traditional procedures. The importance of bilateral cervical fold skin resection is very important. It is clear that measuring skin folds in sternal recumbency rather than dorsal is critical to assessing the amount of skin needs to be resected. The inverted U was one example of that. Ultimately, this procedure is associated with less complications, greater long-term success compared to the traditional methods, and improved quality of life. So for veterinarians who perform this, give us a shot for the right pet owner. And for pet owners who have to deal with a permanent tracheostomy site, a stoma, this is maybe a better option. We'll see. We need larger case numbers, of course, but still a worthwhile paper to learn about. All right, we'll see you guys again tomorrow. Bye-bye.